Hello, my name is Rachel Zeng from the Department of Neurology, University Medical Center Göttingen, Germany, and I would like to show you results from our study with the title Real-Time MRI with Deep Learning-Based Lung Segmentation for Assessing Respiratory Involvement in Inclusion Body Myositis. So inclusion body myositis is typically associated with chronic progressive weakness and atrophy of muscles of arms, legs, and pharynx, while respiratory muscle involvement is considered uncommon. But there are several case reports that have described respiratory impairment in IBM, including mild diaphragmatic dysfunction. So the aim of the study was to assess in a multi-diagnostic approach whether there's a respiratory muscle involvement in IBM and to characterize a potential disease-specific pattern of breathing impairment. Our main diagnostic tool was real-time MRI, which enables dynamic evaluation of complex respiratory motion without triggering of breath holding. We combined real-time MRI with UNet-supported lung segmentation, which is a convolutional neural network, a type of deep learning. And the combination of real-time MRI and UNet lung segmentation enables the detection of early signs of respiratory muscle weakness, as we have demonstrated in a pilot study involving patients with Pompe disease. So on the left-hand side in figure 1, there is an exemplary MRI image of a right hemithorax in sagittal plane and with automatic segmentation of lung and diaphragmatic configuration. And from this automatic segmentation, we can deduce the motion dynamics of the diaphragm, of the chest wall, and of the total lung across an entire breathing cycle, and we can visualize this as a time series. We recruited 22 patients with IBM and 22 patients as healthy controls. The controls were matched by age, gender, and BMI to the IBM cohort. In the pulmonary function test, our IBM cohort showed normal lung function parameters, so there was no sign for any restrictive ventilatory impairment. The ultrasound of the hemidiaphragm showed a slight decrease in diaphragmatic motion during deep inspiration in IBM patients, but this finding was not reproducible on real-time MRI. All patients also underwent a sniff maneuver where they have to quickly inhale through the nose. This is a known maneuver which recruits additional diaphragmatic efforts and can unmask early signs of diaphragmatic weakness. The real-time MRI analysis of respiratory movements in IBM is shown in figure 3. So on the left-hand side, there are exemplary MRI images where the movement patterns of the lung area is visualized as a heat map, with bright yellow showing the area continuously occupied by the lung and dark purple visualizing additional lung area during deep inspiration. The analysis showed no significant differences in the MRI outcomes between IBM and controls, and this included the contribution of diaphragmatic motion and thoracic motion to total lung area change. So there was no sign for any difference regarding diaphragmatic motion or chest wall motion between IBM and the controls. We also analyzed the synchronicity between diaphragm and thorax motion, and this was also not significantly different between IBM and control. So in conclusion, the study provides a comprehensive analysis of respiratory function in IBM patients and did not identify evidence of respiratory muscle involvement in IBM. Diaphragmatic or chest wall patterns seen on real-time MRI did not show significant differences between the IBM cohort and controls. Real-time MRI allows the visualization of different respiratory muscles at a high temporal and spatial resolution, and therefore offers reliable, broad, and unbiased assessment of respiratory involvement in patients with neuromuscular diseases. Thank you very much for your attention.